Hello, hi, and greetings, everyone. Um, I welcome you all to the new video, and it's been quite a long time since I given the last video, and courtesy to the hectic schedule I had in the last 1 or 2 months. So I apologize for that, and that doesn't matter anyway. So the topic on this video will be to discuss on the ABG, or the arterial blood gas. So before moving on to the topic, I like to tell that strictly this video is for the beginners, and there are a lot of advanced concepts in the arterial blood gas, but I don't think those things are necessary to answer the current trend of the questions in the examinations. So this video is basically for the beginners, and I'm going to cover only the basics of what ABG is. So first of all, if you want to take a sample for an arterial blood gas analysis, what would be an ideal vessel? The ideal vessel would be the radial artery. So, why the radial artery? The next question comes to you. The first of all, it is very superficial, and it is easily accessible and palpable as well. So, number one. So, number two, the vein is far away. The radial vein is a little bit far away from the radial artery, so the risk of puncturing the vein and obtaining a false venous sample is a little bit low with the radial artery when compared to the other arteries. So, number three, there is less risk of contamination at the radial site, and also you have adequate collaterals in the form of ulnar artery. So even though there's some problems after puncturing the radial artery, your ulnar artery will take care of the blood supply in the distal areas. So this is why one of the reasons you should perform a test called modified Allen's test. I hope you all know this test. This modified Allen's test should be performed every time and before you puncture the radial artery. So this test is mandatory. You should never puncture radial artery before doing the modified Allen's test. So, what would be the next best choice? The next best choice would be the brachial artery. For example, if the radial artery is inaccessible, it's not palpable, and we're not very sure about the pulsations of the radial artery, or if the modified Allen's test is abnormal, telling that there are no adequate collaterals, then you prefer the brachial artery. So, even though the brachial artery is okay, superficial, palpable, just medial to the biceps tendon, and it's the risk of contamination is less, but still you have a high risk of puncturing the major vein called the cubital vein. So there is still a high risk, higher possibility to get a venous sample, a false venous sample for the matters. And what will be the least most useful site? That be the femoral artery. So whenever it's possible, it is better to avoid this femoral vessel, just because it's deeper. Number one, there is more risk of contamination because the genital area is very nearby, and there are no collaterals with the femoral vessel or from the femoral vessel, and the risk of contamination is very high, and also the vein is very close, increasing proximity of the vein. The vein and the femoral nerve are very close by, and there is a very high likely chance that you can injure the femoral nerve, or you can take a sample from the femoral vein for that matter. So unnecessary. So whenever you do an ABG, it's always preferable to do under an ultrasound if possible under Doppler guidance. I do under ultrasound guidance all the time, but it's always preferable to do an ultrasound. It's beneficial for you, the doctor, as well as for the patients. Why? Because for as a doctor, it can decrease the time duration for obtaining an ABG, and for the patient, it can decrease the number of punctures or minimizes the number of attempts to obtain a successful arterial blood. So whenever it's there and it's available, you just prefer to use an ultrasound and take the arterial blood gas. And what is the ideal anticoagulant of choice for the ABG? It would be heparin. So in laboratory practice, heparin as an anticoagulant is used for very limited conditions. For say, like ABG is one condition. For example, you would use heparin in osmotic fragility test, where you do it for hereditary spherocytosis. So how much of heparin you would use? Ideally, very little. There is no real cutoff. You just take a 0.1 ml of heparin and just try to flush the syringe with the heparin, and after flushing the syringe by moving the plunger to and fro with this 0.1 ml of heparin, just discard whatever the heparin that's remaining. This is the ideal protocol, but there is no clear cut value of how much heparin actually you should use. So these are basically the essence of the crux of the basics, and we'll move to the APG per se, like the problems with acid and base. So first of all, I'll do the basics. So in the basics, first you should know what is the predominant acid in the body and what is the predominant alkali in the body. So the predominant acid in the body would be the carbon dioxide because it can easily combine with water, giving rise to something called carbonic acid. Like we are studied in elementary chemistry that this carbonic acid is a Lewis acid and it can donate protons, and hence the body's major acid is the carbon dioxide. And the major alkali in the body would be the bicarbonate. This is a major alkali in the body. So CO2, you can see that it's a gas, and we inhale and exhale every minute through respiration. So the major modulator of CO2 levels is the respiration, whereas the bicarbonate levels cannot be modulated by respiration, and as such, they are modulated and modified by metabolic events that are occurring inside the body, especially, to be honest, by the kidneys. So any problems with the CO2 will be predominantly because of respiration, and any problems of bicarbonate will be predominantly because of metabolic events. So the problems with CO2 are termed respiratory, and the problems with bicarbonate are termed metabolic, for that matters. So if there is increase in CO2, for say CO2 is an acid, is it right? So it would be called as respiratory acidosis, and decrease in CO2, which means the acid is decreasing. So, and that is termed as respiratory alkalosis. And in this side, if the bicarbonate is decreasing, which means the alkali is decreasing, and it's a metabolic event, and it is called as metabolic acidosis. And if it's going to be increased bicarbonate, in this case the alkali is increasing, and this will be called as metabolic alkalosis. This is essentially, you can call it as a concept number one, and we'll move on to what is called as concept number two. It's a very important concept, and the concept of anion gap. What is anion gap? I would write in a short form of AG. What is anion gap? Basically, it is nothing but the difference in the amount of cations and anions in the body. So we'd measure the major cations in the body would be the sodium and the potassium, and the major anions in the body would be the chloride and the bicarbonate. The difference between these cations and the anions would be the anion gap, and the normal anion gap is normally 8 to 16 milliequivalents per liter. So this is especially, this measurement of the anion gap is important while doing the problems with metabolic acidosis, because there are two varieties of metabolic acidosis you would have been encountering, that is normal anion gap metabolic acidosis and increased anion gap metabolic acidosis. So what's basically happening is, for example, if you take metabolic acidosis, there can be two varieties. It can be either due to pure decrease in bicarbonate or pure increase in H plus. And you see this H plus is again going to combine with this bicarbonate, producing carbonic acid, and it's going to deplete the bicarbonate levels in your body. So if the problem is either pure decrease in bicarbonate or increase in H plus, the net effect is going to be only decrease in bicarbonate. So this is a negatively charged anion which is decreasing, but your body tries to balance the charge by increasing the chloride reabsorption. So the equation is like this, and now your bicarbonate levels are dropping, and your body tries to balance this decrease in bicarbonate by increasing the net chloride amount. So this would balance on either side, and the anion gap would remain normal. And this is termed as normal anion gap metabolic acidosis. And you can also see this normal anion gap metabolic acidosis. There is a mandatory increase in the chloride levels, and these normal anion gap metabolic acidosis can also be termed as hyperchloremic metabolic acidosis. So there are very few causes, and just remember the causes of normal anion gap or hyperchloremic metabolic acidosis. I used to remember by the mnemonic called RAD, radiation RAD, and R for I used to remember as renal tubular acidosis, A for Addison's disease, and D for diarrhea. There are some other few other causes like some like ammonium chloride ingestion, but still, but I just remember these three. These are the three of the most important causes: RTA, Addison's, and diarrhea. RAD. These are the cause of normal anion gap metabolic acidosis, and these are because of either pure loss of bicarbonate or pure gain of H plus without the gain of any other additional extra acid. But when you come to this side, sometimes there can be increase in external acid or some extra acid in the body. So let us not assume one acid to be frank, but some external acid. I'll give you one important example. It could be a lactate, which is very common, otherwise called as lactic acid, otherwise called as lactic acid. What happens now is this lactic acid gets converted into a lactate anion, and also it donates a hydrogen atom. So this H plus is obviously a proton, and this is going to combine with the bicarbonate producing, like carbonic bicarbonate, and this is going to deplete the levels of bicarbonate in the body. So now what happens? Now just put on the equation again. So the bicarbonate levels are dropping, and in this case, because of this external acid, some other acid, the chloride levels are going to be normal. Why? Because this decrease in the negatively charged bicarbonate is compensated by the increase in the anions from that acid. In this case, it's the lactate anion. So the body has no need actually to increase the chloride levels. So it is compensated by increasing the lactate anion or some other anions from any other acid for that matter. It could be salicylic acid, it could be pyruvic acid, or it could be any other thing. So now, but we don't have the formula to measure the lactate ion with this. So according to this formula, the chloride is normal, only the bicarbonate is decreasing, and this leads to increased anion gap. And such kind of acidosis are termed as increased anion gap metabolic acidosis. And this increased anion gap metabolic acidosis is this increased anion gap is nothing but it indirectly indicates this unmeasured anions from an acid. And this exogenous or external acids could be a lactic acidosis, which by Cohen-Wood's classification, it is divided into lactic acidosis type A, type B, and type D, and it could be because of some aspirin poisoning or salicylic acid excess, or it could be because of some pyruvic acid excess, or it could be because of some methanol or ethylene glycol congestion. So whatever could be the cause, but these exogenous acid will raise the anion gap, and it will result in increased anion gap metabolic acidosis. And the next concept would be, this is essentially the concept number 2, the phenomenon of normal anion gap in the increased anion gap. And next concept would be to know the normal values. It's quite simple. Just remember the four magical numbers, the normal values, and this would be the pH. Is normal is 7.35 to 7.45, and the normal PCO2 levels it is 35, sorry, and it would be 35 to 45 millimeters of mercury, and it would be bicarbonate, which would be like 24 to 27 milliequivalents per liter, and the anion gap, which I mentioned already, it will be somewhere around 18 to 16 milliequivalents per liter. So the next event would be to next concept would be to concept number 4, and to understand the compensation in the body. So now just do the basics again. Whenever there is increase in the acid, your body should compensate by increase in the alkali. That is a basic compensatory mechanism. Or whenever there is a decrease in the acid, your body has to decrease the levels of alkali as well. This is the basic concept. And vice versa. Whenever there's an increase in alkali, your body has to increase the acid. And whenever there's a decreased alkali in the body, your body has to decrease the acid. And you can see that both goes in the same direction always, most of the times, if the compensation is proper. So we'll know the importance of this later on, but just trust me, whenever there is increased acid, there would be increased alkali, that would be the compensation, and whenever there is a decreased acid, and there would be decreased alkali as well as the compensation. And one more important point to note is that this compensation can be either incomplete or a partial compensation, or it could be a complete compensation or a total compensation. But please remember, there can never be an overcompensation in the body. Either it could be a complete or fully compensated, full compensation, or it could be incomplete or partial compensation, but our body never does overcompensation for anything. So having known all these of the basics, we'll go to the steps of delineating an ABG. So essentially I would like to tell the 4 steps to delineate the ABG. So step number 1, I would like to see for the pH, and step number 2, identify the primary disorder from the question, and step number 3 would be to find out the compensation, and step number 4 would be to identify if there are any mixed disorders. So how do you identify? These are the 4 essentially the basic steps what you would do. For example, if the pH is decreased, it's a no-brainer. It indicates there is an acidosis in the body. So it could be either a metabolic acidosis, or it could be a respiratory acidosis. So if it's going to be an acidosis, what you're going to see, to look at the bicarbonate and the PCO2 levels, and if it's going to be a metabolic acidosis, your primary disorder will be the decreased alkali, or otherwise the decreased bicarbonate, and if it's going to be a respiratory acidosis, your primary disorder would be the increased PCO2, or the increased acid, or increased respiratory acid, or increased PCO2, or it is called as respiratory acidosis. And normally what is the compensation you would expect is whenever there is decrease in alkali in metabolic acidosis, you would expect a decrease in the acid as well, in the form of decreased PCO2. And whenever there is an increase in the acid, the compensation you would expect is to increase the alkali levels in the body in the form of bicarbonate, that is called as metabolic alkalosis. For metabolic acidosis, the compensation would be respiratory alkalosis, and for the respiratory acidosis, the compensation would be metabolic alkalosis. So coming to the next part, if you are seeing an increased pH, it indicates there is an alkalosis per se. And how would you find out? And it could be either a metabolic alkalosis, or it could be a respiratory alkalosis. So how do you basically essentially find out this? So if it's going to be metabolic acidosis, obviously it's a no-brainer. You are going to have an increased alkali in the form of increased bicarbonate, and if it's going to be respiratory alkalosis, there is decreased respiratory acid, which is the carbon dioxide. You are going to have decreased PCO2 for respiratory alkalosis, and the compensation for the increased alkali is the increased acid in the form of PCO2, that is the respiratory acidosis. And if there is a decreased acid, your body is going to increase the alkali, sorry, decrease the alkali in the form of decreased bicarbonate, otherwise called as metabolic alkalosis. The compensation for metabolic alkalosis will be respiratory acidosis, and the compensation for respiratory alkalosis would be the metabolic acidosis. So this is the primary disorder, and actually this is the expected compensation, and you can see everywhere, everything, the arrows go in the same direction. The arrows cannot go in the opposite directions. So we'll see when to suspect a mixed disorder, and if this is true, and you can conclude to an extent, not completely, but depending on the seeing on the questions you have been asked in recent times, with these arrows you can just conclude that the patient is having only the primary disorder. But if you're not seeing this, and if you're seeing something else, for example, if there is decreased bicarbonate, which is otherwise termed as metabolic acidosis, and now you're not seeing a decreased PCO2, but instead you're either seeing a normal carbon dioxide partial pressure, or in fact sometimes if the arrow goes in the opposite direction, increased PCO2, then you suspect a mixed disorder. The same applies for everything. For example, in respiratory acidosis, if you're seeing an increased PCO2, now the expected compensation would be the increased bicarbonate as well. The arrows should go in the same direction. If the arrows are not going in the same direction, and if you're encountering something like a normal bicarbonate, or if the bicarbonate is decreased, then what would you expect is a mixed disorder. There is a secondary disorder that is also present. If PCO2 is increased, the secondary respiratory acidosis is present, mixed. And if bicarbonate is decreased along with respiratory acidosis, then you suspect then it is mixed respiratory acidosis and a metabolic acidosis as well. And now see this one. If there is an increased bicarbonate, you call it metabolic alkalosis, and the compensation should go in the same direction. The arrow should go in the same direction. The PCO2 should rise along with the bicarbonate, and this is the expected compensation. And if you are not seeing this, and you are going to have a decreased PCO2 or a normal PCO2, which means you're having a mixed disorder. In this case, it should be a respiratory acidosis as well, like respiratory alkalosis as well. And in this case, in respiratory alkalosis, if your normal expected compensation would be the decreased bicarbonate, and the arrow should move in the same direction. But if you're not seeing this, and if you're seeing an increase in the bicarbonate, or a normal bicarbonate for that matters, then it indicates that there is a secondary disorder or a mixed component. And one more thing I'd like to tell is that if there is no mixed disorder and everything goes well, and you have to find out whether it's the compensation is total or the compensation is partial. So how do you do that? So if you are seeing a decreased bicarbonate, it's going to be a metabolic acidosis, and do nothing, and you just look for the pH, and if the pH is normal, or if the pH is decreased, then are abnormal, then it indicates the pH is normal, then it indicates a full compensation, that this decreased PCO2 has brought the pH to normal. But even though this is very rare, but usually this doesn't happen, but it just indicates that your decreased bicarbonate is countered by the decreased PCO2 and has fully compensated by bringing the pH to normal. And for that case, if the pH is decreased, now you can conclude that this decreased PCO2 is not sufficient to bring the pH back to normal, and there is only a partial compensation that is happening. And this can apply to all the tabular columns, everything, and so that you could just, based on the pH, whether it is normal or abnormal, you can just find out that this compensation is either full or partial. And last but not the least, and always whenever you're encountering a metabolic acidosis, please do mention the anion gap. Always, this is very, very important. And whenever you're encountering like metabolic acidosis, it's a must that you should measure the anion gap. Not for anything else, it's usually not needed for other disorders, but metabolic acidosis, measuring the anion gap would be the most important step. So you have to find out whether it's a normal anion gap metabolic acidosis or increased anion gap metabolic acidosis. There's nothing like decreased anion gap metabolic acidosis for your information. And in a nutshell, you can take like these two compounds. This is the nutshell actually. Like I'll tell you that whenever you're taking two values, bicarbonate and carbon dioxide, partial pressure, and bicarbonate, the arrows should go in the same direction. If the arrows are not moving in the same direction, if they are moving in the opposite directions, like this, then it surely indicates a mixed disorder. Or in other words, if one arrow is moving in one way and if the other one is normal, then again you have to suspect the mixed disorder. And this is how, in a basic way, you interpret the ABGs. Hope actually you enjoyed the video, and if there are any queries, just post me. My mail ID would be Dilip Spartan 89 at yahoo.com. Just post me any queries if you have any queries, because I just did the basics. Maybe I would have left something. So if that is the case, and yes, you can just mail me up and you can ask it out. And thanks for now. Thanks for everything. See you. Bye bye.